This is my STYC03 musculoskeletal exam. Before completing the exam, I have ensured levels of hygiene by tying up my hair, removing all jewellery, following the 6-step hand wash rule, wiping down the bed. For today, we can't adjust the bed height as this bed does not adjust, but in a normal clinic I would. I have checked all contraindications with my client, but just to check again, Stephen, is there any reason why I wouldn't be able to treat you today?
No.
Okay, so from his subjective assessment, Stephen presented problems with the knee, and so I'm going to go forward and complete a full joint assessment on the knee. We're going to go forward with a static observation. For the purposes of the assessment, we're only going to look and perform tests on the right knee. So looking at the right knee, we're looking for any swelling, deformities or bruising to indicate acute injury, which there doesn't appear to be any. Coming around to the front, we're going to look at posture and muscle mass. So looking at his muscle mass, I can see that Stephen has increased muscle mass in his vastus medialis compared to the rest of his quadricep muscles. Also here I can see the angles of his knees. So here we would look for knee varus or knee valgus. Varus is where the knees point laterally out to the sides, and knee valgus is where they point in medially, also known as knock knees. Here we can also look at the Q angle. So this is the relationship between the patella and the quadriceps. Here we would stick a clinical goniometer onto the patella and angle it towards the ASIS. Unfortunately we can't today. In a normal Q angle for a man, you would expect to see 14 degrees, and in women it is higher. A wider Q angle can often cause maltracking of the patella, and it is often caused by muscle imbalances. If we come down further, we can see Stephen's knees, feet are slightly overpronated. And then if we come round to the side and look at Stephen at the side, I can see that his pelvis is slightly posteriorly tilted. And again, you can see that those feet turn out to the side. Coming around the back, we can see that there is no increased muscle mass in his hamstrings. They both seem to be the same. His popliteal lines on his back of his knees are equal. If we come down, the gastrocnemius seem to be increased muscle mass, but this could be due to the fact that Stephen does quite heavy training loads. And down further, the feet again are overpronated. We're going to go forwards and do a dynamic assessment and look at Stephen's gait. So Stephen, if you can walk to the wardrobe and back continuously until I tell you to stop, just so I can analyse. So when he's walking, we're looking for feet position, so I can see that they're overpronated. His knees are also pointing out to the sides in a varus position. When we're looking at his hips, they seem to be at the same level. There's no signs of limping at all. And if we carry on walking, just looking at the knee during the gait cycle, I can see that it's sufficiently flexed and extended, although we would perhaps like to see slightly more flexion. And he can stop there. And he's also hitting his heels quite deep on the ground, creating quite a lot of noise. So although he's got the heel to toe action, there's still quite a lot of weight being put through that foot. Next, we're going to go on to palpation. So we're checking muscles, tendons, ligaments and bones for any pain, tenderness or tightness. So Stephen, is it okay for me to treat you?
Yes.
Okay, I'm just going to put my hands on you and I'm going to feel for tightness in the quadriceps. Tightness in the quadriceps could be causing pain in the patella. If we come down, the patella tendon, the quadricep tendon goes into the patella tendon over the top of the patella. So Stephen, is there any pain around your patella? No. No? Okay, and that goes down to the tibial tuberosity. So if we move the knee into a flexed position, keeping the heel on the bed, and we can feel the bony points. So I'm feeling the lateral and medial condyles of the femur, as well as the head of the fibula and the lateral condyle of the tibia. And there's no pain around there. If I feel along the tibia, is that okay?
Yeah.
There's no pain there. And within the tibial plateau, there is no pain. So we also have our ligaments that consist of our anterior cruciate ligament, our medial collateral ligament, our posterior cruciate ligament, and our lateral collateral ligament. So if I feel along there, we're feeling for just tightness and pain and tenderness, which there doesn't appear to be any. So from here, Stephen's going to turn into a prone position on his stomach. I can palpate his hamstrings. So Stephen, is there any increased pain along there?
No.
Okay, so his hamstrings don't appear to be overly tight. If we go down over the joint line at the back of the knee, we can feel his popliteal line. Is there any pain there?
No.
coming down into the gastrocnemius, there is slight increased tightness in the gastrocnemius from what I can see, which could be causing an issue. Next, we're going to go and clear joints above and below just to rule out any injuries there. Okay, so we're going to go forwards and clear the joints above and below by doing some simple movement tests. We're going to start with the hip first, doing a hip quadrant test. So if we flex the knee and flex the hip, see if you can bend your knee. That's it. Okay, so we're going to bring the hip up, and you should be able to get around 0 to 125 degrees of hip flexion. Then we're going to bring the leg out to the side, and we should be able to get around 0 to 45 degrees of abduction. And if we do external rotation, so I'm going to put my foot on the lateral side of the ankle and just turn Stephen's foot inside, and we should be able to get around 0 to 42 degrees of external rotation. If I bring it back up into flexion and then go into adduction, we should be able to get 45 to 0 degrees of adduction. And then if we do internal rotation, so hand goes around the bottom of the foot on the medial side, and then just bring the ankle towards me, and we should be able to get 0 to 45 degrees of internal rotation. So Stephen, was there any pain in any of those movements?
No.
No? Okay, so we're going to finish with extension. So if you put your foot flat on the table and just slide your leg down as far as you can. Perfect. So we should be able to get around 105 to 0 degrees of extension. So that looks great. We're going to go ahead and clear the ankle joint. So Stephen, follow these simple movements, and then I'm going to add some overpressure. So first of all, can you plant flex your foot, pointing your toes all the way to the floor for me? So in this position, we would expect to see between 0 and 50 degrees of plantar flexion. I'm going to add slight overpressure. Is there any pain? Okay, good. And then we're going to do dorsiflexion. So if you point your toes all the way to the sky for me, here we should expect to see between 0 and 20 degrees of dorsiflexion. I'm going to add slight overpressure. Is there any pain? No. Okay, now we're going to do inversion. So if you turn your toes in for me, good. And if I add overpressure, we should see between 0 and 35 degrees of inversion. And turning out to the side, we should see between 0 and 25 degrees of eversion. And is that okay? Good. Okay, so we're going to go forward and complete a full joint assessment as there is no problems. Okay, so we're going to go forward and complete the movement test that we need to do for the knee, and these are going to be active movement, passive movement and resisted movement. Okay, so the first one that we are going to do is knee flexion. So Stephen, keeping your foot flat on the table, I would just like you to bring your knee into right angle as far as you can for me. Okay, perfect. And now we're going to do it passively. So I'm going to add a slight bit of overpressure. So if we push against it, let me know if there's any pain. No? Okay, so if it was a positive result, you might have some pain and the client may feel tenderness around the knee area. And in flexion, we're looking for around 0 to 130 degrees. And now we're going to do it resisted. So Stephen, if you want to bring your foot down to about 30 degrees, perfect. Okay, and I just want you to bring it into flexion like we just practiced, but against my resistance. Okay, can you do that for me? So just slide your foot up the bed. Good. Okay, so for muscle strength, we're looking at the Oxford Strength Scale. So 0 would be that there is no contraction at all and they can't perform the movement. And 5 is that there is maximum muscle contraction and maximum strength against a resisted movement. So there didn't seem to be any problems with Stephen's flexion in a supine position. So next we're going to go into extension. So just from here actively, we're going to go into extension. So Stephen, if you just move your foot along the bed into a fully extended position of your knee. Good. Okay, and then from here I'm going to add a passive overpressure. So I'm going to put my hand just over the tibial tuberosity on the tibia, and then I'm going to push down on the top of the quadricep tendon just to put it into some full extension. Is there any pain there?
No.
No? Okay, so you expect to see 120 to 0 degrees of extension. And then we're going to do it resisted. So if you bring your leg back up into angle, perfect. And then I just want you to push against me. Okay, good. So again, I'd say that is around a 5 on the Oxford Strength Scale. So now we're going to do flexion and extension in a prone position. If you could bring for flexion your heel up to your gluteus area, and we can just see how good your knee flexion is for me. Okay, so that is an active movement. Again, like before, I'm going to add overpressure. So if I push down, is there any pain there? No. No? And there seems to be a spongy end feel. So a normal end feel will often feel spongy unless you're doing bone on bone, which can sometimes feel hard and quite abrupt. And then we want to do a resisted movement. So Stephen, if I hold onto your calf, and then you're just going to bring your foot up to your ankle again. Okay, good, and there's maximum contraction there, fantastic. Okay, and then from here we're going to do extension. So we're just going to get Stephen to bring his foot all the way back down. You can do that for me, so that's an active movement. Good. We can't do this movement passively in this position, but we can do a resisted movement. So Stephen, if you bring that back up for me. Good, and then you're just going to push against my hands. Good, all the way down. Okay, so again, he's got a maximum contraction. If there was any issues with flexion and extension in this movement, then we might see that they can't perform the contraction, or when it's resisted, then it's harder to perform the action. Okay, so we're just going to go forward and finish the movement tests on the knee, doing internal and external rotation. So Stephen, if you could just bring your whole lower leg and internally rotate for me. Good. And then if we can try and apply a bit of overpressure. So I've got my hands just around his ankle, and I'm just going to apply a bit of overpressure. Is there any pain there? No. No? Okay, so if there was pain, you would indicate there might be apprehension on the client's face, or it might struggle to go into the range of movement. And then if we can do it resisted, so if you bring it back into a neutral position, good. And then I'm going to hold it here, and if you can try and resist the movement. And how is that? Okay. Okay, so usually an internal rotation there would be around 0 to 45 degrees. So if we do external rotation, so we're going to go the other way this time. Stephen, if you can point your toes out to the side for me, as far as you can get round. Okay, good. And then I'm going to add some overpressure. So again, hands are either side of the ankle. Is that okay? Okay, and then I'm going to add a little bit of resistance. So if you try and push against me. Okay, so there's good amount of muscle contraction there. So for external rotation, you would expect to see around 0 to 25 degrees in range of movements. Okay, so some additional muscle tests that we're just going to perform just to make sure there's no spasming around the muscles is a resisted knee extension test. So this is going to check for any spasming or tightness in the quadriceps. So if I put my hand on the quadricep tendon just above the patella, and then my other hand over the tibial tuberosity, and then I'm going to get Stephen to lift his leg up whilst having a resisted movement. So if you could just lift your leg up so it's straight for me. Good. Okay, so there doesn't appear to be any spasming in the quadriceps. In fact, there's quite a lot of strength within that movement. Okay, so we're just going to test the hamstrings now. If we bring the leg up to perform a straight leg raise, so I'm just going to take hold of the Achilles tendon with my hands, keep my other hand on the top of the quadriceps and raise the leg as far as we can get it and push it back. So there is some slight tightness in the hamstrings, but there appears to be no spasming or cramping, which is good. And then the next one we're going to do is just going to test glute media to see if there is sufficient stability around the medius area and in the knee. So Stephen, if you just raise your leg up for me, good, and then back down. Okay, and then we want to keep the hip nice and flat. So we're going to do a resisted movement, so I'm going to push slightly down, and then you're going to bring your leg up for me. Good, and then back down. So if the client wasn't able to perform that movement, it might indicate some instability and a lack of firing in the glute medius, which can often lead to knee varus and knee valgus. So we're going to move on to the special test. So this looks for the integrity and see if there's any issues in any of the structures around the knee. So So first of all, we are going to do the posterior cruciate ligament test. So the first test is the posterior sag test. So Stephen is going to move his foot into a 90 degree, move his knee into a 90 degree angle, keeping his foot on the bed. Okay, and all we're looking for is to see if the tibial tuberosity has dropped. Okay, so a positive test would indicate that it had dropped and that there was sag in the knee. The sensitivity and specificity of this test are 79% and 100%. And often PCL injuries are caused by severe hyperextension or rotation mixed with knee varus and knee valgus. Another test that we can do that will test PCL laxity is a posterior draw test. So Stephen, I'm going to put my hands around the back of your knee, around the back of your calf. Okay, try and keep your foot flat on the table. And I'm just going to pull your foot, lower leg towards me, okay? Ready? So in a short, sharp motion, you're going to pull the leg towards you. You would expect to see that the leg would kind of move forwards. If the test turned out to be positive, there would also be tenderness and apprehension from the client. So this test has a sensitivity reading of 90% and a specificity reading of 99%. Okay, so to check the anterior cruciate ligament, we are going to do two tests. The anterior draw test and the Lely's lever test. So for the anterior draw test, we're going to bring the knee up into 30 degrees of flexion. Okay, then we're going to sit on the foot to keep it nice and stable. I'm going to place my thumbs over the tibial tuberosity and then in a short, sharp motion, bring the calf towards me. So my fingers are around the back of the calf, my thumbs are on the tibial tuberosity. Are you okay? Yeah, I'm going to bring it towards me. 3, 2, 1. Okay, so a positive test would be indicated if there was instability in the knee. You might see that the knee joint actually comes forwards. And also pain and apprehension can be noted by the patient's face. Now, the second test that we're going to do to test ACL is the Lely's lever test. So we're going to bring the leg down into full extension. I'm going to place my hand underneath the calf in a fist and the other hand on top of the quadricep tendon. And then in a minute I'm going to push down in a short, sharp motion. Now a negative test would be indicated by the heel rising, and a positive test would be indicated by the heel staying flat on the table. So ready? So here we can see that the heel is rising. Okay, ACL injuries are commonly seen amongst sport, usually in sports that require a quick change in direction, such as netball or football. They are also more commonly present in women due to the increased Q angle. I'm going to go forwards and test medial collateral ligament laxity using a valgus stress test. So to do this, we are going to flex the knee. I'm going to put one hand on the medial side of the inner thigh, and I'm going to put the other hand on the medial side of the ankle. And we're going to use my body as a lever to see if there is any gapping over the medial collateral ligament. So if we pull the ankle out laterally, we'll be able to see if there is any gapping. If there is gapping, this indicates a positive test along with any apprehension on the client's face or increased levels of pain. Common injuries associated with MCL is an MCL tear. Now I'm checking for LCL laxity. So for this, we're going to put the leg up in a fully extended position. Okay, I'm going to put my hand on the medial side of the thigh and the other hand on the lateral side of the ankle. And I'm going to keep the thigh steady with my hand and bring the ankle towards me to see if there's any gapping over the LCL. So if this test is positive, we will see gapping over the LCL. There will also be pain and apprehension on the client's face. Usually this injury is commonly associated with lateral collateral ligament tears. We are now moving on to meniscus tests. So the first one we are going to do is testing joint line tenderness, and this is checking for tenderness within the tibial plateau. So all I'm going to do is palpate along the tibial plateau Is there any pain in there?
No.
No? Okay, so a positive test, you would expect to see pain, again, apprehension on the client's face. Meniscus is used as a shock absorber, and so often if there is activities which cause significant impact, the meniscus can be teared. Moving on, we're going to use McMurray's test to check for meniscus. So we're going to bring the hip and the knee up to a 90-degree angle. We're going to place our hand at the bottom of the foot and the other hand on the quadricep tendon and compress the knee and the ankle towards each other. Once it's in this position, we're going to scoop around using internal rotation and external rotation. Okay, and we are checking to see if there is any knocking or clicking around the joint and if there is any pain within the meniscus. Usually in meniscus injuries, the medial side is injured more commonly than the lateral side due to the lack of movement within the medial side of the meniscus. Another test for meniscus is Tethley's test. So for this one, the client is standing. They're going to stand on the leg of the injured knee, and the other leg is going to be slightly raised. And take hold of my hand. Good. And then we're going to flex these slightly, and then I would like you to internally and externally rotate your knee like we practiced at the beginning. That's it. Good. And is there any pain there?
No.
So we need to note locking, clicking or grinding. To progress it further, we can take it into a 30 degrees of flexion. Good. And then twist from side to side again. Good. Okay, and put your foot flat on the floor. So we might see some apprehension or pain. So we're going to check for the patella, and we are seeing if there is any excess fluid or pain. So we're going to put the back of my hand onto the patella, and we're going to do the patella sweep test. So pressing down, we're going to go around in a circular motion, and there doesn't seem to be any excess fluid. Positive test, you would expect to see pain, excess fluid. Common injury is effusion on the knee. The next test we're going to do to check for any patellofemoral disorders is the Clark's line test. So I'm going to put the L's of my thumb over the knee. Then I'm going to ask the client if he can contract his quadriceps. I'm going to apply a downward pressure on the knee. Is there any pain there?
No.
No? Okay, so there is no pain on the knee. There might be, in a positive test, discomfort or even failure to complete the test. Okay, so the next test is the patella apprehension test. So we're going to put the knee into a 30-degree angle, and I'm going to put my thumbs on the medial side of the knee and push the patella out laterally to the side. So there is no movement here. Any lateral displacement or discomfort and pain would indicate a positive test result, and it can be used to detect patella dislocations. The final test we're going to do is Noble's compression test, and this is checking to see if there is any issues with the IT band, such as IT band syndrome. So what I'm going to do is place my thumbs on the lateral condyle of the femur, and then the client is slowly going to raise the leg into extension and down to flexion. That's it. Good, and down. Okay, and back up. So what we should be able to feel is the IT band going over the lateral condyle of the femur. Any positive test results will be indicated by any pain in the area. There might also be pain and tenderness when palpating for the lateral condyle. The last section of the test is the functional test. So this is basic day-to-day movements that the client might be struggling with. So the first movement we are going to do is a simple squat. So Stephen, all I want you to do is try and keep your back in a neutral position. You're going to squat down and then come back up. Okay? Okay, so as he does that, we're looking to see if there's any instability in the knee or if there is any pain around the knees or the hips. Next one we're going going to do is a lunge. So first, if you can lunge with your bad leg forwards, and then we'll try the other way round. Good, and go again. Okay, so again we're seeing if there's any instability in the knee, and that might be indicated by the knee shaking, or even if there's any varus or valgus, so sometimes when they lunge the knee will turn in or out. The last one we're going to do is a single leg stance. So Stephen, if you can stand on your bad leg for me. Okay, so as Stephen raises up onto his bad leg, we should be able to see if his hip stays in the same position or if it drops. If it drops, it indicates that there is a lack of glute firing, especially in glute med, and it might mean that we need to strengthen the area. Now that we've completed the joint assessment, if any of the tests haven't come back positive, then we could have started to introduce exercises or coping mechanisms for Stephen to deal with the pain around his knee. Because none of the tests did come back positive, it might be a good idea to look at the joints above and below again and complete a full joint assessment on there. For now, I would recommend that if the patient has got joint line tenderness and any pain within the joint, that they should stop physical activity until a solution can be found and the client is comfortable to complete activity again.